Imagine standing at the edge of two truths. One, a person is suffering, confused, maybe even dangerous, and refusing help. Two, that same person has rights, the right to say no, even if we don't understand why. Welcome to one of the most painful crossroads in psychiatry, involuntary treatment. It's where compassion, ethics, law, and human dignity collide. And for the psychiatrist, it's not always a clear path, it's a dilemma. What is involuntary treatment? Involuntary treatment is when a person receives psychiatric care, medication, hospitalization, or restraint without their consent. It usually happens when someone is seen as a danger to themselves, like in suicidal crises, to others during violent or psychotic episodes, or when they're gravely disabled and unable to care for themselves. In many places, laws allow mental health professionals to detain someone for evaluation, sometimes 24, 48, or 72 hours, even longer, if a judge agrees. But here's the question. Just because we can force treatment, should we? The psychiatrist's role. The psychiatrist's job is to heal, to help, to do no harm. But what happens when helping means overriding someone's will? When a patient is screaming no, and the doctor must decide if yes is the ethical choice, it's not always about what's legal, it's about what's right. And sometimes those aren't the same thing. The argument for involuntary treatment. Let's start with the most common defense. Sometimes a person's mind is so clouded by illness, psychosis, mania, deep depression, that they can't make rational decisions. They may believe they're being followed, or that they don't need food or sleep, or that their life has no value, even when it clearly does. In these moments, the illness is speaking louder than the person. And in these moments, psychiatrists may step in, not to punish, but to protect, to stabilize, to preserve life, to create a space where healing becomes possible. Sometimes involuntary treatment saves lives. There are countless people who once resisted help, but later say, I didn't want it then, but I'm glad someone intervened. The argument against involuntary treatment. Now the harder side. Involuntary treatment can feel like a violation, a betrayal of trust, a stripping of autonomy. Imagine being locked in a hospital room, restrained, medicated, with no say in what happens to your body or mind. It can be terrifying, traumatizing, and sometimes re-traumatizing for people with histories of abuse or control. Even when well-intended, forced treatment can leave deep scars. And sometimes the system gets it wrong. People get held for being odd or non-compliant, not because they're truly dangerous. Cultural misunderstandings, racial bias, poverty, homelessness, all of these can shape who gets labeled a risk. So we have to ask, when does care become control? When does protection become power? The legal and ethical balance. Ethically, psychiatry stands on 4 pillars: autonomy, respecting a person's right to make choices; beneficence, acting in the person's best interest; non-maleficence, do no harm; justice, fairness in treatment. Involuntary care challenges all 4. You're overriding autonomy in the name of beneficence. You might harm someone emotionally while trying to help medically, and systemic biases may make justice harder to uphold. This is why involuntary treatment is rarely a black and white decision. It's a moment-by-moment ethical calculation, guided by law, science, empathy, and humility. When the system fails, let's not romanticize it. Our mental health systems are often underfunded, overcrowded, and overwhelmed. Involuntary treatment can become a shortcut for a system that doesn't have time to build trust. Emergency rooms become holding pens. Patients get discharged without follow-up. And psychiatrists, overworked and burned out, make life-altering decisions in minutes. In some places, people are hospitalized not because they're a threat, but because there are no safe housing options, no therapy access, no family support. That's not psychiatry, that's systemic failure wearing a white coat. Stories behind the statistics. Behind every involuntary hold is a story. A mother crying in the waiting room, a brother who made the call no one wanted to make, a patient who feels trapped or saved. Sometimes people say thank you, sometimes they never speak to you again, and as a psychiatrist, you carry both. Because this work isn't clean, it's human, and humans don't fit neatly into laws or diagnoses. So what's the answer? There's no perfect answer. But here are some guiding principles many professionals follow. Use force only as a last resort. Build trust first. De-escalate. Listen. Try every voluntary option. Respect the person's dignity even in crisis. Speak calmly. Explain clearly. Never forget you're treating a person, not just symptoms. Be aware of bias. Race, gender, culture, and disability can influence how danger is perceived. Pause, check yourself, follow up. After stabilization, reconnect. Repair the relationship if possible. Involuntary care without follow-up is just a bandage. Advocate for better systems. We need more outpatient support, crisis centers, mobile teams, peer support, and community-based care, so forced treatment becomes less necessary. The psychiatrist's dilemma. The dilemma is this: you swore to do no harm, but in some moments, every option feels like harm. Let someone spiral, or hold them against their will, give a sedative, or risk them hurting themselves or others. Wait longer, or act now. There's no glory in these decisions, no easy sleep afterward, only the hope that you did your best, that the patient might someday see it as care, not cruelty, and the willingness to keep asking hard questions. Because psychiatry, at its best, is not about control, it's about compassion, even and especially when that compassion is hard to carry. Final thoughts. So, is involuntary treatment ethical? Sometimes yes, sometimes no. It depends on the moment, the intent, the context, and the courage to see the full human in front of you. But one thing is always true: it's never easy. Not for the patient, not for the family, not for the psychiatrist, and maybe that's how it should be. Because when we're dealing with people's freedom, safety, and minds, the moment we stop wrestling with it is the moment we've stopped caring.